is by Dr. M. R. Rajagopal, who already introduced. So he is the director of Trivandrum Institute of Palliative Sciences and chairman of Pallium India. And today he will speak about the concept of palliative care. So there are many people in this group who know about palliative care, but I think we will take this chance to refresh our memory and will uh, and palliative care is expanding day by day. So we will hear more about from Rajagopal sir. So sir, it's over to you.
Thank you. Thank you. Sunil, Raju. Great beginning. What a group. Amazing. Professors, vice chancellors. To Zena and to Kat, my apologies. I will be speaking in the language called Indish. Indish is the English language that is spoken in India with an Indian tongue. It will be a bit difficult for you to understand. Apologies, Zena and Kat. Anytime you want me to repeat something, just put it on the chat box. Apologies to you for my accent. Sloga, I know that you understand me. Uh, shall I tell you a story? True story. Once, a mother and her, she must have been around 42, and her 16-year-old daughter came to me. The mother was having bleeding PV and also pain in the lower abdomen, pain and bleeding. I took a history. I wanted to know what was troubling her most. That's something that I usually ask. I asked Shanta, that's not her real name, I'll call her Shanta. Shanta, what is it that bothers you most? She looked into my eyes with a stare, was silent for a few seconds, and then she burst out crying. I don't, how many of you have had this experience of patients crying? Sometimes we say meaningless things like, don't cry, everything is going to be okay. Or we say, hey, this is a hospital. The thing to do, ladies and gentlemen, is not to do anything. Just be silent. That person has to cry. That's the only way in which they can collect themselves. Usually, nobody sits and cries like that for more than a minute. In a few seconds, they collect themselves, wipe their eyes, and say, I'm sorry. Well, when she had finished sobbing, she said, my daughter has not eaten anything since yesterday. The story was that they had a small amount of money. They had debated whether to buy a little tapioca. Tapioca is the poor man's food traditionally in Kerala. Very inexpensive. It used to be very inexpensive. They wanted to buy a kilogram of tapioca and eat it, or they wanted to save the money for the bus fare the next day because somebody had told them about our palliative care clinic. They decided to starve. They did not eat after lunch the previous day. They starved through the night and came to us in the morning for a consultation. The woman had had excellent treatment of the disease from our institution. She had cancer of the cervix. She had had surgery, recurrence, radiotherapy, some chemotherapy. But the game that is being played, you will remember this. She goes back to gynecology. They say, why are you coming here? You have to go to oncology. She goes to oncology. We have already told you, we have given you surgery, radiation, chemotherapy. There's nothing more to be done. Go back to gynecology. Referral game, especially for the poor. There is another kind of referral game for the rich that I am not going into now. And then she went from doctor to doctor. I saw a sheaf of prescriptions. Generally, most prescriptions had 4 medicines or 3. That is some kind of a ritual, is it? We seldom write prescription for own medicine. We almost feel some obsessive compulsive neurosis to add a multivitamin and a nutrient liquid. The poor woman and the daughter, because nobody had given them the proper information, was doctor shopping. Whatever little money they had was spent on these medicines that come in attractive curvaceous bottles with many vitamins and minerals, where they did not have food to eat. Well, we'll come back to the story. But I just want to warn you. Maybe you all have seen this story or without really observing it. Because I know, because till I came into palliative care at the age of 40 or so, I also used to run away from these stories. I would say meaningless things. Don't worry, we are here for you. Everything is going to be okay, my good God. When the 2 specialists have told me that I am dying. So we are talking about that woman and her daughter and about 10 million people in India like her. Let me share a screen and show you a presentation. I have called it Moving the Margins of Healthcare because between these 43 people attending this session, this is what we are going to do. Why does the margins of healthcare, why does it need to be moved? This is the definition of health. Physical, mental, and social well-being, not merely the absence of disease or infirmity. I studied this definition in medical college because this definition is as old as me. I did not see this being practiced. I was not taught how to provide physical, mental, and social well-being, neither principles of symptom control or psychological support or social support was taught. You and I were taught about diagnosis and disease treatment. Diagnosis, treatment of the disease. We were not taught how to comfort somebody, how to relieve the mental anguish, how to buy a meal for somebody who is starving. This is why I said the margins of healthcare need to be moved. The margin, comfortable margin for healthcare that we have drawn now is very convenient for us. Examine the patient, do the scan, give the definitive targeted therapy, and get lost. In my country, India, and unfortunately, Zena and Kat, in Philippines also, the majority of people do not get pain relief. Basic pain relief reaches less than 2% of the needy. The Lancet Commission report, about which I'll tell you, estimated that there are 7 million people in India, with 7 million patients in India with serious health-related suffering. That's an underestimate because it took only 20 different conditions into account. If you include other conditions, the number will be much more. And if you include the families, the daughter who starves with the patient, then imagine what is the magnitude of the suffering. Your duty and mine is to do what we can. We alone can take away a little bit of the suffering away. And that's how things change. In addition to the fact that we do not treat pain and suffering, we inflict suffering. Let me stop screen share for a minute and ask you, I want you to think and answer this question. If you are not afraid to think about your own death, where would you like to die? We will have a separate session on end of life care on another day. I'm not going to the details, but I'll tell you one thing. When I am dying, my degrees will be of no value to me. The awards that I have got will mean nothing. My car will mean nothing. The only thing that will matter to me will be the love that I give and the love that I get. And ladies and gentlemen, with our end of life care today, in our brave new world, we shut people up inside ICUs. Dr. Roop Gursahani, a neurologist in Mumbai in Hinduja, says corporate hospitals are fortresses into which the poor cannot enter and the rich cannot get out of. Day before yesterday, Sunil and his colleague Arjun saw a patient whose daughter had to fight for a whole week to get him discharged. They wanted to advance at very advanced metastatic cancer. They wanted to treat him in an ICU. Is this how you would like to go? We do this. Sloga, in this country, this problem is 4 times worse than in USA. I have data. USA or UK, people get withdrawn from the ventilator when the treatment is futile, at least to a certain significant number. Here, if you have money on the pocket, you die on a ventilator. Horror. This is unimaginable cruelty. And this is going to shock you. These are the numbers of people whom we together, our healthcare system, destroy. 55 million Indians. Hey, Zena and Kat, sometime I'll look up the figures for Philippines also. I don't know. But here, 55 million Indians, 65% or more of people have no insurance or no social security or government system support. They spend out of their pocket. More than 4% of our population are pushed below poverty line. And now we wonder, why is that the public is angry with us? I mentioned that we do not treat pain and suffering. I mentioned that we cause unnecessary suffering by giving inappropriate end-of-life care. And would you believe it? This was what happened to that woman in the last phase of her life. They went on referring her from OP to OP. We started treating her pain. But one night, we did not have any IPO, inpatient care at that time. She developed bleeding. She was rushed to the hospital. She was put into the ICU. And the daughter was said, bring blood urgently. The 16-year-old daughter had to run from pillar to post in the middle of the night. trying to get blood as if that could save the woman. And the woman died without taking one more look at the 16-year-old daughter. I still have her in my conscience. And the girl was denied one last look at the mother who was dying. These are realities, and let us have this clearly understood. Palliative care is not only for the end of life. I mentioned end of life, so I am making a point of this. Palliative care is not only for the end of life. When should palliative care start? Give it a thought. When, at what stage of the disease should palliative care start? You want to put your answer in the chat box? When should it start? As soon as you diagnose Dr. Mahalakshmi, thank you. Hey, Dr. Mahalakshmi was not here at the time of introduction. She is a dean in a health university. Welcome, Dr. Mahalakshmi. As soon as diagnosis, day one of any treatment. Okay, perfect. Thank you. Enough for me. But if I may add one more word, if I am the patient, I want it to start when my suffering starts, which may be even before my diagnosis. You may be fiddling around with the scans and things. I may be breathless. I want it now. It is not only for the end of life. By no means is that so. This is how the WHO defines palliative care. 18-year-old definition, still valid. It's about quality of life. Not only the patient, but also the family. Not only for Shanda. Palliative care is also for her 16-year-old daughter. Because imagine her social and psychological issues that a 16-year-old daughter of a single mother, lives with. They use the word life-threatening illness, but I'll go on to this. So for this, we have to prevent and treat pain and other problems that are physical, breathlessness, the fungating wounds, the bleeding, the breathlessness, everything, and psychological and social and spiritual issues. These are the things to be done about which we will all be learning together soon. But WHO, as a footnote, adds it is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life. Some of us are palliative care physicians. The others, if you ask me, the others like Dr. Mahalakshmi and many others, like Zena Cat and many others, have a better opportunity to practice palliative care by incorporating it, integrating it into their routine healthcare practice. Every patient that Dr. Mahalakshmi, who is a surgeon, sees has some of these physical, psychological, social, and spiritual. And when she gives a smile and assures, I am going to do the best for you, or she says, you look extremely worried. You want to tell me what about it? When she says that, she is delivering palliative care. Well, I apologize to you for this long definition by WHO, but here it is, something I would like you to remember. This came out of a 2017 Lancet Commission report. This phrase, serious health-related suffering. Palliative care is prevention and management of serious health-related suffering. Serious health-related suffering. And that would be in all these 4 domains, as we said: physical, spiritual, emotional, and social. That girl and the mother, Shanda, had several other problems. They had a small hut. Shanda's husband had deserted them as soon as the diagnosis was made. They said it was trouble. He left, abandoned them. This is not rare in our country. A 16-year-old girl and a thatched hut where anybody can open the door and walk in. No security. The mother's major concern was, if I die, what will happen to my 16-year-old daughter in our society? She will not even be able to bolt the door properly at night. She hated herself because an abandoned woman, what would she feel? And they were frequently talking about both of them committing suicide together. Her spiritual pain was not only the anger with God, it was also the feeling, I wish I were dead. Life has no meaning. These are all things that we will understand. We attempted to do some things for all these, and that's what the palliative care should be doing. But Raju, will you be ready with the video? Ladies and gentlemen, all this together. Hey, wait a minute. Who is the founder of palliative care movement globally? Who founded palliative care as a movement? It was Dame Cicely Saunders. There is one nurse doctor in this group. So Cicely Saunders was a nurse turned social worker turned doctor. She coined this phrase, total pain. When the mother burst out crying and said, my daughter has not eaten since yesterday, the mother was expressing total pain. And I have not heard total pain expressed more beautifully than by my colleague, our director of programs at Palliative India, Smriti Rana, whom you will meet with another session on another day. But Smriti, during a TEDx talk, talked about total pain. That's a 4-minute video or a 5-minute video. Let me show it to you now.
In palliative care, we have this notion of total pain, pain that takes into account the life circumstances of the patient that contribute to his or her experience of suffering. I came across that concept quite early in my life, and I mean, in my career, and I thought I understood it, theoretically at least. And then one day, the home care team that I was a part of was called in to see this fisherman in one of the outlying villages of Trivandrum. We parked our van some 400 meters away, made our way down this narrow, undulating path. We could hear this man's screams well before we got to his house. And on approaching the house, we were assaulted by this stench, which made me gag. And when we entered his home, we were met by this helpless young woman, and behind her on the bed, a man in his 40s, who was the source of the screams. He had a myriad problems and a feeding tube. And on closer examination, we found that he also had a bowel obstruction that was not allowing him to pass what his wife was so diligently feeding him because she didn't know what else to do to look after him. And as a result, he was regurgitating his own waste. It was awful. Anyway, he was cleaned up, analgesics and other medication were administered, but no matter what we did, his pain would not fall below 6 on the pain scale, which is essentially a scale of 1 to 10, 10 being the highest, where we ask people to score their subjective pain. So finally, this benevolent and wise doctor that I have the absolute privilege of calling my mentor, he took this man's hand in his own, and he asked him, he said, what's your biggest concern right now? What is bothering you? What an odd question, I thought. I mean, the pain, the humiliation, the despair, and just the misery of everything that he was experiencing. I mean, the answer was glaringly obvious to me. The man didn't say anything for a long time, and I started to get fidgety. The silence was starting to get awkward and strained, to me at least. But the good doctor, he held steadfast. And after about 6 long minutes, and I know this because I was timing it, this man very softly said, "All I wanted was for my children not to be fishermen. And now they're going to be just that." He knew he was dying, and he knew that his wife would not be able to support the children on her own. And this one fact was causing him far more agony than anything else that he was going through. So one of the things we strive to do in our program is to undertake the educational needs of children from disease-ravaged families that can no longer afford to send them to school. But this process takes about a week from when the child has been identified. In this case, however, we sped up the processes. Donors were found, pledges were made, documents were signed, all to see these two children, aged 8 and 10, through to college. We returned to the fisherman's house the next morning, and he was asked what his pain was. Still 6, he said. He was then shown the documents, and he was told, "It is done. Your children will not be fishermen." The transformation on that man's face was magical. And once he had digested that information, he was very gently asked one more time, "What is your pain now?" 1. He died 3 days later, pain-free. And that, my friends, is total pain. And that was when I truly learned my first lesson in being still and allowing.
Thank you. Thank you for listening. And I hope you got that description of total pain, a conglomeration of his pain, his bowel obstruction, everything, but also his poverty and his worry about his children not getting education, his anxiety, his depression, his feeling of why am I alive? And all this together was his total pain, as Smriti so totally described. Ladies and gentlemen, many of us have lived through our professional life running away from this. We concentrated on the disease. And sometimes we treated the disease and caused more suffering. My colleagues and all the palliative care people across the world are saying, we refuse to turn away. We will look at the suffering. We will do what we can about it. This is what we will learn during this course. How many sessions? 19 sessions or whatever. The diagnosis will not be a consideration. Whatever is the diagnosis, we will do this. And understandably, Dr. Rama, Dr. Kanakasabhavati, everybody, we have worked in a certain way. You, the medical professional, even if helped by the nurses, cannot do this. That woman, Shanta, could have been given pain relief by me. Maybe I could have done something to reduce her bleeding as a doctor. But to reduce her total pain, we needed to work as a group. A few phone calls to a certain social organization, to somebody whom we knew, telling about such a family, can you help? That girl should have at least one room where she can lock herself up. And can you and a social worker talk to the extended family, arranged such that an aunt who was living alone and they would be living together so that the girl will not be alone when the woman died. This had happened. The woman was told, you can come here on any day. We are here to look after you. We failed her because we were not there at night, and she had to suffer in an ICU. And spiritually, we did not read Bhagavad Gita to her. We did not give her religious speeches, but we gave her love. We gave her care. So much so, at one point, Shanta told a volunteer, I thought my God had deserted me. He has not. He sent you people to look after me. That is spiritual support without preaching. Doing God's work is what I call it. Giving them love and care. That together forms the essence of palliative care, for which we will certainly have to treat pain and physical suffering. You will all hear about the application of Psychosocial Chapter so that pain can be treated effectively. You will look for, you will be, you will learn the management of various symptoms. For example, when that woman became breathless, she became breathless because she was so desperately anemic and possibly her hemoglobin was 2 or 3. That ICU was horrible, not to be done. Give her oxygen if it helps. If her hemoglobin is 3 grams, it will not help. What I actually tell patients is, let us try this for 10 minutes. If you feel better, we will continue it. I'm an anesthetist. In an operation theater, I'll be very uncomfortable if there's no pulse oximeter in place. But in a palliative care unit, I would prefer if we do not have the pulse oximeter going all the time. Because if it is there, you start treating the oximeter, forgetting the patient. More than anything else, telling Shanta, we are here to look after you. We will do our best. You have been bleeding. That's why you are breathless. We are giving you medicines to reduce the breathlessness. And what medicines would that be? Not in Shanta's case, but if there is a tumor causing breathlessness, we would use corticosteroids and morphine. The senior anesthetist may be a little surprised. I was when I heard it first. When I appeared for my MD examination, very close to Safdarjung Hospital, of course, I was asked a question, tell me one absolute contraindication for morphine. I said dyspnea, and that was correct. Today, I teach the drug of choice for breathlessness in incurable diseases is morphine, used in the right dose, in the right fashion. Now, I am not going to treatment of all symptoms. What I am asking you doctors to do is that possibly you will have to take a duster and erase several things from your memory bank. Many things may need to be unlearned, from hard science to a combination of science and humanity. I'm not, I only gave you one example. If one of my patients comes in the middle of the night, this is what our team will do. Not straight away push them into an ICU for solitary confinement till death. You must remember that there are several things that you may miss. The pain and the breathlessness were easy. To find the man's worry about the children, we had to dig deeper. There are many issues like that you may never know unless you dig for them. Dive deep into the cold water. Just remember that in an iceberg, only 1/8 is visible above the surface. When you have taken them away, the other things surface. And some things you will still have to dive deep, like sexuality issues, like spiritual issues. During this course of the next 19 sessions, These are all things that we will talk about. You, the hard scientific doctor, will learn a little bit about how to tackle spiritual issues, not necessarily by preaching to them, not necessarily by reciting the Bible or the Quran or the Gita, but using love and humanity. I'll skip that and leave you with this one question. This is a extract from a poem by the famous poet Mary Oliver, The Summer Day. Tell me, what is it you plan to do with your one and wild, precious life? What is it you plan to do with your own and wild and precious life? We, as far as we know, we have one. Even if you believe in reincarnation, you don't know if it is going to be as a tiger or as a bear. We have this existence as a human being. And if we can infuse more humanity into the practice of medicine, which I believe is a huge blessing that I have been endowed with, then we can use that to relieve a lot of suffering. I believe it comes back to you in the form of blessings. And you will need all this in your own home. Remember, we also are going to be patient someday. Our loved ones may have to be looked after. This is not only for others, this is for ourselves. So, ladies and gentlemen, thank you very much for listening to me patiently. I see that we have 10 minutes more for discussion before the case presentation starts. So, thank you very much.
Thank you, sir. So now we have 10 minutes to clear the doubts. So anybody can have your doubts, or you can also write it in the chat box.
If your connectivity is bad, you write in the chat box. Thank you, Dr. Kanaga. And Dr. Nirupa, you were absolutely right about Dame Cicely Saunders as the founder of the palliative care movement. The nurse turned social worker turned doctor, Cicely Saunders.
Do you suggest any basic book for us to read, during this course, which would help?
Raju?
So we will be sending a soft copy of Indian Primer of Palliative Care. So that can be a reading material, and if you want to purchase, there is one book called Introducing Palliative Care by Dr. Robert Toykros.
Sure.
Raju, has the link for the primer have been given to them already?
No, sir. It will be sent along with the learning material of first session, sir. This session.
So today. Dr. Kanagasabha, a free book is available for free download. That Raju will send it to you today.
All right. Thank you.
Sir, can I ask a question? Mahalakshmi here.
Yes, Mahalakshmi.
Sir, it's like if you think metaphorically, it is what you say is correct. But sometimes what we see, especially I operate children, I operate newborns, which like we know that when we start, sometimes we start with an odds of 50%. That what can really save this child. And sometimes we really feel that we are doing what I call as extreme care, right? But at that point of time, our training or our conscious does not say, okay, we can stop at this point of time. Many a times we keep thinking, what if they can come through? What if the child makes it? What if we can make the child live for a few more years, even with all these things? So sometimes that conflict is there. Are we trying to play God kind of thing? that I find it sometimes quite often also like thinking about it. Like, am I right in saying, yes, I'm not going to treat this baby any longer? How do we actually overcome this?
Mahalakshmi, thank you. By the way, everybody, Mahalakshmi is the dean of a university, medical university, and is also a surgeon, also a palliative care person coming into it and helping with the education program. Mahalakshmi, thank you for the very profound question. Now, in India, legally, the duty of your duty of care of the doctor to the patient is not legally defined. In the UK, there is a law. Legally, it spells out what's the doctor's duty of care. But the duty of care has been defined by ICMR. It says your primary duty of care is to relieve suffering. It is to cure sometimes, it is to relieve often, and to comfort always. And there exists no exception to this rule. I'll repeat that. The duty of care of a healthcare provider is to relieve suffering, is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. There exists no exception to this rule. Mahalakshmi, you are involved with education. You must have gone through so many ethics discussions, etc. I bet you will find nowhere a statement that a doctor has a duty to stretch out the dying process, prolong life at any cost. No, I haven't seen that written anywhere. But by training, you and I were trained. Fight, fight, fight. The rhetoric of war. Fight the disease. Can the child at least live for 3 days more or 6 months more? Whose decision? Leave the child's situation for a moment. If it is me, I know I will have to die someday, right? I have only 10 to 15% chance of dying a sudden death. 85 to 90% chance is that I will go through a prolonged illness. At that time, will you try to stretch out the dying process? Let us talk about the adult. Then we will come to the child. Who is to decide? Not you, doctor, in spite of your 7 degrees. Me. This is my life. We'll talk about more at the time when we deal with ethics, but this is my life. I may tell Dr. Mahalakshmi, you have been very kind to me. Thank you very much. But I don't want that chemotherapy. I have gone through the 6 cycles. And as you said, the response has been poor. Enough is enough. Just keep me comfortable. Don't let me be breathless anymore. That's my choice. Dr. Mahalakshmi, I would like you to go with my decision at that time, provided I have been empowered with enough information. That's your duty, to keep me as informed as I want to be. Okay, we come to the case of a child whose decision, naturally the legal guardians are the parents. The parents will say, I can't leave my child. Please do something, Dr. Mahalakshmi, keep him alive. Natural. Any parent would say that. But what I hope we will all do is to work with the parents from the beginning. Do not give them false hope. Be honest, but be with compassion. I will tell them, I have told this to several parents. I wish I didn't have to tell you this, but I have the unfortunate duty of having to tell you the truth that from a medical point of view, a cure is not possible. Doctor, don't say that. Don't say that. Don't reject my child. I will not reject your child. I will never abandon your child. I will be with you and your child all through the child's life. we will do the best for your child. But the best for your child may not be meaningless chemotherapy. In fact, if we relieve the child's pain and breathlessness, maybe he will eat a bit better and live with us a bit longer. I have to give them the right information. The parents will take so much longer to take a decision about a child than about themselves. That's understandable. My duty is to hold their hand and walk with them, and not to do anything that is pointless. And if we'll come to that more at the time of dealing with ethics. Sorry, I took too long with the answer to that question. Any other question?
Thank you, sir.
Thank you, Mahalakshmi.
Any more questions or comments?
Will you all give a thought to the question that I ended up with? Mary Oliver, what is it you plan to do with your one wild and precious life? We'll come back to the question later on another day. Thank you for listening to me so patiently. I think it is time for the case presentation, as there are no more. Oh, or maybe we'll just wait for a few more seconds in case there is any question. Okay, Sunil, thank you.
So we had about um, palliative care. What is it? Uh, Actually, the first definition from WHO, it came in 1990, and which says it is the active total care of patients whose disease is no longer responsive to curative treatment. So it was no longer responsive to curative treatment in 1990, and in 2002, the present definition, which sir has shown, it says it's an approach that improves the quality of life of patients and families affected with life-threatening illness, but it continues to say that it is applicable from the early course of illness. So that was in 2002. So from 1990 to 2002, there were some changes, and then came the Lancet Commission report, where it was described palliative care can be provided to any patient who has serious health-related suffering.
Can I disturb you for a moment? There's a lot of sound disturbance in the background. Cannot
Okay.
hear you properly. Yeah.
How is it now?
It's still coming, something,
Okay, how is it now?
There is background disturbance. I don't know what. Probably why you're touching this or something.
Rajlakshmi, is there any problem?
So can you hold your headphone little away from you? We can hear your breathe also.
Okay, how is it now?
No, that's too feeble.
Too feeble, sir.
Why don't you take away the headphones and speak
remove
directly into
the
the computer?
Absolutely.
Okay. So I hope
Now
I'm
it's
using a mobile. So
Sir, I think it is clear now. You can speak.
okay. So I was talking about the changing definition of WHO, and and when it came to Lancet Commission, the word serious health-related suffering was used. I think the horizon of palliative care is expanding, and basically it aims to improve the quality of life of patients and families, not only of the patients but also of the families, which sir has pointed out. Um, by um, by How can we do that? By looking at the problems that or sufferings the patient and family is going through, that is physical, psychological, social, and spiritual problems, and do as much as possible to relieve this. We may not be able to relieve all the problems the patient is suffering, but we can do many things for the patient and family. So, thank you, sir. And I think we will move on to patient story. So this will be the structure of our echo session. First, we'll be having a faculty presentation followed by discussion, and then a patient story followed by discussion. So today's patient story will be presented by Dr. Arjun, who is one of the palliative care physician here at Trivandrum Institute of Palliative Sciences. So from the next session onwards, one of you have to present the patient story. Arjun, it's over to you.
Thank you, sir. Good evening, everyone. I'm Dr. Arjun Devarajan. I'm a palliative care physician with Palliative India. So moving on to our case presentation. So today we'll be discussing about a 39-year-old male who was diagnosed with traumatic quadriparesis with stage 4 pressure sore on sacral region and left gluteal region. So he presented with constipation since 2 days, bed sore over sacral region and gluteal region, and moderate pain over the hip region, and along with urinary leakage. So going to the history, he had a history of fall while carrying a weight, followed by neck pain and weakness of both limbs. And he was diagnosed with traumatic quadriparesis in August 2015. He was admitted and got treatment from one of the government hospital and was discharged after 1 month. Around 6 months later, he developed a bed sore over the sacral and gluteal region. Both were stage 4, and there was history of pain over the hip and wound site for more than 2 weeks. Pain over the hip region, which he scored 5 out of 10. It was an intermittent burning type of pain, bilaterally, and at the wound site, he scored 4 out of 10, and which was a continuous throbbing type of pain. Due to this, sometimes they keep the wound open. He also had disturbed sleeping pattern and decreased oral intake. On examination, he was conscious, oriented. His temperature was 98 degrees, pulse 82, respiration 20 breaths per minute, blood pressure was 120/70, and all systems were within normal levels. So describing the pressure source, they were warm and tender. Exudates were present. Channeling was also present. They were irregular in shape and foul smelling. The treatment and investigations done, routine investigations were done. His hemoglobin was 10, total count 34,000, polymer was 80%, lymphocytes 18, eosinophils 2, and platelets were 1.6 lakhs per microliter. Serum creatinine was 0.9, sodium was 132, and potassium 4.
So there are some technical issues here. We will get that.
Sorry for the trouble. Let's get back. So coming into the psychosocial aspects. So he was a 39-year-old unmarried man living with a 65-year-old mother in a rented house. He had one sibling and who is married and living separately and not caring or helping them. He used to be a manual laborer and was the breadwinner of his family. Now his mother is working as a manual laborer and she is taking care of him. The main source of income for the family is his mother's daily wages, her pension, and some of his friends who are helping them. They have already taken like rupees 1.5 lakhs from a private finance bank for the treatment purpose. He, who was a devout Christian, now unable to go to church, this makes him very sad. He communicates through his cell phone, and he often says to his mother, like, I don't think I can walk, so please don't spend money over my treatment. So his main concerns are the pressures of pain and financial problems. Now, to summarize, he's a 39-year-old man with traumatic quadriparesis with bed sore present over the sacral and left gluteal region, both stage 4, with pain over the hip region. Okay, now the points of discussion. Do we need to provide palliative care for this patient? What are the problems faced by this patient? And what all can be done for this patient and his mother? Thank you, and over to you, sir.
So thank you, Arjun. We have a 39-year-old paraplegic patient with pressure sore and urinary tract infection, possibly. So the questions are, do we need to provide palliative care for this patient? So I invite any one of you to discuss these points. You can have your comments. Anybody?
Hello.
Yes,
Yes, Dr. Shirley.
please speak.
As to my observation, I do recommend that he really needs a palliative care.
Can you?
Because, he requires a palliative care. There is a very reason being, first of all, he is bedridden and almost lost hope in life.
Yeah.
And then he is also bothered much about his financial background also. And then that make him to say that don't spend any more on me because I'm not going to be better. In a way, he is going into a state of depression. So I really feel that he really requires palliative care. Thank you.
Yeah. I see there are few doctors who says his pain need to be treated. So actually we can approach this patient from the point of total suffering. So he has physical problems. He has psychological problems, social and financial problems, and spiritual problems. So his quality of life is also less. So we can try to improve the quality of life of this patient and his family by providing some relief for these aspects of suffering or domains of suffering. So physical problems, we can do something like pressure sore management, management of urinary tract infection, management of pain, etc. We can do. And the psychological problems, actually, we have to find out what all are the things going through his mind. So maybe he was the breadwinner, now he's unable to go for any job, and he might be thinking, I'm a burden to the family. And as we told, he might be may not be in clinical depression, but he might have a depressed mood, etc. And maybe thinking of his mother. So all of this might be the psychological problems. And socially and financially, if you look at from the social perspective, he's unable to go out and to meet his friends. So in a way, he is isolated, even though he can talk over the phone. That's why he keeps the communication with the friends. And his role in the family as well as in the friend circle has changed now. Previously, he was earning and he had a respectable position. But now he is not earning and he is bedridden. So the status uh, in the friend circle and family might have changed. So these all are social problems that patient is facing, and spiritual problems like he was used to go to church every day, but now he is unable to go. So these all are problems with the patient. And if you ask his mother, she will have many other things to tell us. So we have to consider all these problems, and then we have to find the solution for this. So this patient is a suitable patient for providing palliative care. What can be done for this patient and his mother? So which I saw that somebody has told. Uh, yeah. Okay. So what can be done for the patient and his mother? Anybody
Actually, if,
can? Yeah.
yeah, after his initial problems that wound sore, pressure sore is treated and urinary tract infection is controlled, we can actually provide him with mobility. We can think about giving him a wheelchair if it is possible, so that that will take care of his social problems, and also will provide him with a means for earning. Like we still see some people in wheelchair going around and doing some selling of small objects and all that. So he may not feel so much of an economical burden to mother and family. So we can try and support, we can provide him a means for livelihood. Maybe he can do some job as sitting in one place, telephone booth or things like that. No, if we are, have some connection with the NGOs, we can try and do that also. So that he regains dignity of self in life.
Yeah, thank you. Exactly. So this patient, he's feeling a burden for the family. So what we can do is we can help him with some vocational rehabilitation. Uh, uh, so he might need a wheelchair so that he can be mobilized, and he will be able to make something like umbrella or bag making, etc. That we can teach so that they will get some earning every day, which will be helpful to regain his status in the family as well as in the friend circle. And he can make connections with his friends as well as he can go to church, which will be helpful for him because he was very sad because he is unable to go to the church. So if he can arrange a wheelchair, definitely it is going to help him from all the aspects. Uh, the vocational rehabilitation is something which we need to be careful because each family, the uh, there will be the things in the family will be different for different people. Uh, so suppose we are going to give him some goat or cow rearing, then we have to inspect the surroundings, the neighbors, etc. So if they doesn't have, if they don't have much land, then it will be difficult for us to give the goat or something like that. So we have to consider all the factors into all the factors before providing vocational rehabilitation. So I think we gave a wheelchair, and then he is doing poultry farming now. So he is happy with that. Is Arjun there?
Dr. Arjun have left, sir.
Okay. So anybody has anything more to add to this discussion?
Nowadays, the wheelchair bound people are connected through social media. So probably if he is not yet aware or part of such groups, we could encourage him to join. So maybe his old friends are still active. So he may not be able to connect with them in the same way. But other people who are wheelchair bound, if he has like a smartphone and WhatsApp, and then he starts making new friends, I think it will give new meaning to his life.
Yeah, thank you. That's a very important point. So peer group support is something which we can encourage, and um, that will help him to find out, as you told, new things in life. And actually, he can also find out how somebody else has adjusted to this type of living, which will help him to go through this. So that's very important. Anything else? Yeah, somebody has written, Dr. Sloga Iyengar has written, maybe a priest can be invited to their house if he cannot to go to church. Yeah, possible. Can his other sibling be contacted for support? Yeah, that's a possibility. But we have to understand the family dynamics. Uh, why the other brother is not supporting the family? So, is there any problem? So, all for to find out this, we usually have a social worker in our team, so that the social worker will talk to the sibling, and first we have to talk to the family and find out their perspective, why they are not why the other sibling is not giving any help, and only with the help of family we can contact the other sibling. Anybody else?
Sir, about the pain of this patient,
Yeah.
It seemed like neuropathic, but there was two kinds of pain.
Okay. So, Dr. Ravi, shall we talk about pain in the coming sessions, because next session will be on pain. So, yeah, mainly there are two different. Broadly, we can divide pain into two: nociceptive as well as and neuropathic. So, the pricking pain, which is radiating to the leg, might be neuropathic, and the pain on the pressure sore should be nociceptive. But we will talk about pain in the coming session.
Yeah, fine. Thank you.
Are there any more comments? So Rajalakshmi, if there are no more comments, I think we can wind up the session. But before winding up the session, I think um, from next session onwards, somebody has to present the patient story, and